Hello everyone, welcome to Dr. Rahul's Medicine. Now in this video we will talk about pheochromocytoma. Okay, in this video we will talk about pheochromocytoma. Now it is the catecholamine secreting tumor of adrenal medulla. Catecholamine secreting tumor of adrenal medulla. Okay, now what are the major catecholamine that are present in our body? The major catecholamine in our body are adrenaline, noradrenaline and the dopamine. Okay, so in the pheochromocytoma the level of catecholamine will be increased, so the level of adrenaline, noradrenaline and dopamine will also be increased. Okay, now this pheochromocytoma is also called as the chromophenoma. Now why it is called as chromophenoma? As this pheochromocytoma is arise from the chromaffin cell. This pheochromocytoma arise from the chromaffin cell. Okay, now this is our chromaffin cell. Now this chromaffin cell can be present either in the adrenal gland or it can present outside the gland. Okay, now if the tumor is arise from the adrenal medulla, it is called as the adrenal pheochromocytoma. And if the tumor is arise from outside the gland, it is called as the extra-adrenal pheochromocytoma. Okay, now there is one more term for the extra-adrenal pheochromocytoma. It is called as the paraganglioma also. Okay, now let's talk little about extra-adrenal pheochromocytoma. Now this extra-adrenal pheochromocytoma, also called as the paraganglioma, can arise from two different places. Okay, it can either arise from the sympathetic ganglia or it can arise from the parasympathetic ganglia. Okay, now the most common site in the sympathetic ganglia, it is the organ of Zucker candle. Okay, and the most common site in the parasympathetic ganglia, it is the carotid body. Or the jugular bulb. Okay, now let's see what are the hormones which are produced by this gland. Now we have the adrenal pheo and we have the extra-adrenal pheochromocytoma. Okay, the hormone which are produced by adrenal pheochromocytoma, these are adrenaline followed by noradrenaline and a little amount of dopamine also, as these three are the major catecholamine in the body. But the hormone which are produced by extra-adrenal pheochromocytoma is mainly noradrenaline. Now why mainly noradrenaline? Let's see here. Normally what happens, this noradrenaline is being converted into adrenaline, and this conversion take place in the adrenal medulla. Okay, and the enzyme which help this process is called as the phenylethanolamine N-methyl transferase. Okay, so this enzyme is exclusively found in the adrenal medulla. So the conversion of the noradrenaline into adrenaline will occur only in the adrenal medulla. Okay, so in case of extraadrenal pheochromocytoma, as this enzyme is not present, so this conversion will not occur. As the conversion will not occur, so the level of noradrenaline will increase in the extraadrenal pheochromocytoma. Okay, now let's move to the clinical feature part. Now in the clinical feature, earlier there was a rule of 10 which was applied for the pheochromocytoma. Rule of 10. Now what according to rule of 10 is that the 10% pheochromocytoma are bilateral. The 10% pheochromocytoma are malignant. And the 10% pheochromocytoma are extraadrenal. Extraadrenal. This was the rule of 10 that was earlier applied, but now this rule is out of date. Okay, now let's see what is the classical triad. In the clinical feature, we have a classical triad in the pheochromocytoma, and this classical triad can be remembered by a mnemonic PHD, where the P stand for the palpitation, H stand for the hypertension, and D stand for the diaphoresis. Okay, this diaphoresis is also called as the sweating. Okay, now remember one thing here is that the hypertension is always episodic. That is, patient will not have hypertension whole day. Okay, now why the patient have the episodic hypertension? Let's see here. Now as we all know, the catecholamine have very short half-life, have very short T half. Okay, so it will remain in the blood. It will remain in the blood for a few minutes only, for a few minutes to few hours only. Now, when the level of catecholamine is high in the blood, the patient will have hypertension. Now, once this catecholamine level start falling, then what will happen? The patient will have hypotension. So this pheochromocytoma is not only about the hypertension, it is also about the hypotension. So the patient will have the hypertension, which is followed by the hypotension. Okay, now let's see what will be the other clinical feature. What will be the other clinical feature in a patient of pheochromocytoma? The patient will have tachycardia. The patient will have fine tremor. The patient will have the impaired glucose intolerance. And the patient will have the hypercalcemia. Okay, so the electrolyte abnormality associated with the pheochromocytoma is the hypercalcemia. Okay, now let's move to the diagnosis part. How we will diagnose this condition? Now this pheochromocytoma, we have the two methods to diagnose this condition. Now either we can perform the screening test, or we have a investigation of choice or definitive diagnostic method. Now in the screening method, we can do 24-hour urinary metanephrine level, or we can do 24-hour urinary catecholamine level. And the third screening method we have is the 24-hour vinyl mandelic acid. Okay, now among these three, the first one, which is the 24-hour urinary metanephrine, it is the best screening method. But the most common method among these three, which will ask in the exam, will be vinyl mandelic acid. It is the most commonly asked in the exam. Okay, so level of vinyl mandelic acid is increased. in the urine. Now let's what will be the investigation of choice. The investigation of choice for pheochromocytoma will be 24-hour plasma fractionated metanephrine. Okay, this will be the investigation of choice for the pheochromocytoma. Okay, after diagnosing this condition, we have to manage this condition now. Now, the management of the pheochromocytoma is mainly surgery, but before performing surgery, we have to manage the patient pre-operatively. We have to manage pre-operative. Now, in the pre-operative management, what we will give, we will follow one regime that will give patient first alpha blocker and followed by beta blocker. Okay, we always give alpha blocker first and then the beta blocker. Okay, now the drug which used in the alpha blocker, it is the phenoxybenzamine. It is the phenoxybenzamine. And drug used in the beta blocker is the propranolol. Okay, now what this alpha blocker will do, it will control the BP. It will control the BP. And what this propranolol will do, it will control the tremor, it will control the tachycardia. Okay, now suppose if the patient by mistakenly taken the beta blocker first, then what will happen? Okay, now if by mistakenly if the patient has taken the beta blocker first, then alpha blocker, this regime is absolutely contraindicated. Okay, now but by mistakenly if patient has taken the beta blocker first, then alpha blocker, then what will happen? Now let's see the basic point here. We have the alpha receptor and we have the beta receptor in the body. The alpha receptor responsible for the vasoconstriction and the beta receptor responsible for the vasodilation. Now if the patient has taken the beta blocker first, what will happen? This vasodilation function will be hampered here. Okay, and the patient will have the more and more vasoconstriction. If the patient have more vasoconstriction, it will lead to the severe hypertension. And as the patient is already having a very severe hypertension, so it will worsen the condition. So this regime is absolutely contraindicated. So always remember, we always give alpha blocker first and then the beta blocker in case of the pheochromocytoma. So this is all about the treatment part of the pheochromocytoma and all about the pheochromocytoma. Please like this video, please share this video, and please subscribe to channel. Thank you.